Hi and welcome everyone to this webinar on the WHO Abortion Care Guideline, a webinar that is hosted by the IBP network. My name is Caroline Ekman, and I am a consultant to the World Health Organization, where I work for the Prevention of Unsafe Abortion Unit. I am also part of the IBP network, which is a network of more than 100 member organizations and over 19,000 professionals in the field of SRHR. And for those of you who are not so familiar with the IBP network, I thought I would just give a very quick introduction. So we are based at the WHO headquarters in Geneva as well. And we support the dissemination and implementation of evidence-based guidelines and tools revolving around SRHR. And we do this through encouraging collaboration, scale up of best practices, and knowledge sharing. And by hosting a variety of different knowledge sharing activities, including webinars such as this webinar that you are attending today. And I am pleased that the Prevention of Unsafe Abortion Unit and the IBP network have joined forces today to deliver this webinar on the newly released abortion care guideline. But before we begin, I would just like to go over some housekeeping rules. So this webinar will be recorded, and we will be sharing the link to the recording shortly after the webinar. The presentations will be held in English, but we do have simultaneous interpretation to both Spanish and French. So if you do prefer to listen in any of those languages, you can simply click the interpretation icon that you will find here on the Zoom platform. We will allocate some time for questions and answers at the end of the webinar. So if you do have any questions, you are free to post them at any time during the webinar. Please use the Q&A icon that you see here on the Zoom platform. Okay, and on that note, I think it's time that we officially get started. So I would like to hand over to Vinoj, who will be our moderator today. Vinoj, please go ahead, the floor is yours.
Hi, everybody. Good morning, good afternoon, and good evening. My name is Vinoj, and I work for an Indian NGO called Ipas Development Foundation, and I've been working with them for 20 years. When I got invited to be the moderator of this session, I was feeling slightly inadequate, and I was wondering, what am I doing with all these luminaries in the same panel? The only justification I thought was, though I was involved in the guidelines preparation, one among the many, I thought when the 2012 guidelines came out, the WHO guidelines came out, we, along with stakeholders in India, had various consultations, which finally led to the revision of the Indian Comprehensive Abortion Care, the National Comprehensive Abortion Care Guidelines, and based on the recommendations of these consultative workshops, as well as certain things which probably influence the new amendments that happened to the abortion law. As you all know, from policy and advocacy arc, the starting point very often is this WHO guidelines. And this webinar, from there, this is the foundation on which we could leverage various actors at the national, regional level, could leverage changes in policy. So I see this webinar and the subsequent conversations around this WHO guidelines as a starting point for making safe abortion a reality for all persons needing one. So I'm very delighted to have all of you here, delighted to be part of this process. The next slide, please. So very quickly, to talk to you about, give you a background about the agenda of the webinar, the structure of the webinar, we will start with a broad overview of the concepts of the guideline, and then move on to specifics, including the abortion regulations, and then they come into the looking at services across the continuum of care, which includes the pre-abortion, abortion, post-abortion, including very, very importantly, self-management approaches. And finally, also look at various service delivery models. This we all would try to pack within the next 1.5 hours, which includes addressing questions from the participants. So it is my big pleasure to start the workshop, the webinar, with introducing Dr. Bela Ganatra, who many of you may not need an introduction. The next slide, please. She is an MD, and following that, she did a master's in health behavior from Harvard University School of Public Health and a postdoctoral in reproductive health from Johns Hopkins. The Bela heads the unit on prevention of unsafe abortion and is involved in evidence gathering, synthesis development, and estimating magnitude and consequences of unsafe abortion. So over to you, Bela.
Thank you, Vinoj. And it really is a great pleasure on the behalf of the entire Preventing Unsafe Abortion unit to welcome you all to the first in these series of webinars about the guideline. You saw from the agenda that Vinoj projected that at this point in today's session, we will not be able to do very much more than just give you an overview of the guideline content and the recommendations. But over the course of the next several months, there will be other webinars based on different themes, which will allow us to explore the guidelines, its recommendations, and implications for implementation in more details. The launch of this guideline in March of this year is really an important landmark for all of us in the SRHR community because it is our guideline. And it also for us here at WHO marks a milestone in 50 years of work on the topic of preventing unsafe abortion within WHO and the HRP special program. This is in fact the third of our integrated guidelines. For those of you who've been following the trajectory, the first WHO guideline was released in 2002. And at that time, that was the very first time that we were able to bring in considerations around law and policy side by side with service delivery and clinical care into a guideline. 10 years later, in 2012, when the second of our integrated guidelines came out, we were able to strongly bring in a human rights element into the guidelines as well, and to bring out recommendations on rights and policy side by side with recommendations on clinical care and service delivery. 10 years later to today, you will see that the integration of rights, health, law, policy, clinical care, and service delivery is even more integrated, and both health and human rights are integral to this new framing of our guideline, about which you will hear shortly. All of this underpins the central premise on which the guideline and our work is framed, that is a recognition that abortion is healthcare. Abortion is common. I think you are all familiar with the statistics that tell us that half of all pregnancies are unintended. Around 60% of them end in an induced abortion, making this a common experience for women worldwide. It is safe. It is common, it is safe, It is a primary care intervention. It is health care. And as you will see in the guideline, throughout, we talk about not exceptionalizing abortion, whether it's in the case of health regulations or whether it's in the case of integrating it within health systems. So with that, let's move on straight to a discussion of what we will find in the guidelines. Vinoj, back to you.
Thank you, Bela. It's my pleasure now to introduce Caron. She's an OBGYN. She holds a Bachelor's of Art degree at the Yale University, a Doctor of Medicine from the Virginia Commonwealth Health University, and a Master's of Science from London School of Hygiene and Tropical Medicine. Within the PUA, Kim is responsible for the abortion care guidelines, and she led the process for the current clinical and health system recommendation. Being part of this and having worked with Caron in this long process, I know how long and comprehensive this whole process has been. And I'm sure Caron would have found this a very, very busy period, but at the end of it, a very satisfying journey. So over to you, Caron.
Thank you, Vinoj. Good day to everyone. I'm very excited to be here, and we will start off by providing an overview of the abortion care guideline. So what is this guideline? Next slide, please. So this guideline, the abortion care guideline, is a consolidated and updated guideline that's replacing all the prior publications and related products coming from the Prevention of Unsafe Abortion Unit. So you see here, this is including safe abortion, the 2012 technical and policy guidance, then the 2015 health worker roles in providing safe abortion and post-abortion contraception. And then the most recent, the 2018 medical management of abortion. So this guideline presents the complete set of all WHO recommendations and best practice statements relating to abortion. Next slide, please. So acknowledging that legal, regulatory, policy, and service delivery contexts may vary from country to country, the recommendations and best practices described in this guideline aim to enable evidence-based decision-making with respect to quality abortion care. So our target audience includes policymakers, program managers, members of NGOs and other civil society organizations and professional societies, and of course, health workers and other stakeholders. Next slide, please. So as Vinoj has mentioned, this guideline is a result of a development process that has taken time. That started in 2018 and finalized in 2021. And this involved staff members from both WHO headquarters, regional offices, and a vast range of country expert contributors and support personnel. So global experts in clinical care, health systems, human rights, and law and policy were convened to review the evidence and draft recommendations in a series of virtual meetings. The final guideline development group then convened in 2021 to finalize these recommendations and we ensured to include youth representatives and a human rights advisor. So you see here on the left, the green image, and this is the WHO Integrate framework. And this was used as a basis for deciding on the direction and strength of each recommendation and includes consideration of the following criteria. So the balance of health benefits and harms, human rights and social cultural acceptability, health equity, non-discrimination and equality, societal implications, financial and economic considerations, and feasibility and health system consideration. And as an additional criterion, quality of evidence was applied across and to each of these criteria. Next slide, please. So here are the key concepts underpinning this guideline. Next slide. First and foremost, abortion is healthcare. As Bela had pointed out, this is central to and being carried throughout our guideline. And WHO has included comprehensive abortion care in the list of essential health services in recent technical publications and guidance. However, despite being a safe and effective healthcare intervention, an estimated 45% of all abortions are unsafe due to the multiple barriers that exist to access of care, such as legal restrictions or abortion being regulated under criminal law. Next slide, please. Another key concept to this guideline and to keep in mind as we listen through these presentations is the emphasis on quality abortion care. And this is going beyond safe abortion care. So this new guideline highlights the need of abortion care to not only be safe, but also take into account the other dimensions of quality care. So this is being effective, efficient, accessible, acceptable and person-centered, and equitable, meaning care that does not vary in quality based on personal characteristics of the person seeking that care. So quality of abortion care is foundational to this guideline. Next slide, please. And the third key concept to keep in mind as we travel through our guideline is that the human rights integration. So while human rights have been addressed in previous work, including several previous WHO publications, including guidelines coming from our Department of Sexual and Reproductive Health, this new guideline integrates human rights standards and obligations in a more formal and systematic manner. So human rights are integrated into the guideline as an overarching theme across the continuum of care. So each clinical care, health service delivery, and non-policy recommendation is accompanied by a box listing the key human right considerations relevant to the recommendation or the broader topic. Next slide, please. So structure of this guideline. Next slide. So in this guideline, we have previous recommendations that have been carried over and have remained unchanged. Then the majority of our recommendations are labeled as updated. And so this means they have undergone the whole process of scoping of the search and review of relevant evidence and take into account that WHO integrate framework, all in accordance to the WHO Handbook of Guideline Development. And then we also have additional recommendations. And these recommendations have emerged from reviews of new research questions. So as noted before, this presentation and this webinar focuses on the updated and additional recommendations. And of course, for the complete overview of all the recommendations, including the unchanged ones, please refer to the new guideline. Next slide, please. So to clearly indicate the strength and direction of each recommendation, we have these 3 recommendation categories. And so we use the following wording throughout this guideline. 1 is recommend. So this is a strong recommendation in favor of the intervention. Then we have a suggest, and this is a weak recommendation. It's still a recommendation, but it's a weak one in favor of the intervention, but it's accompanied by additional qualifying wording or conditions in order to apply that recommendation. And then we have recommend against, which is a strong recommendation against the intervention or in favor of the comparison. Next slide, please. So this slide is showing the conceptual framework of the guideline, which I will walk you through. This framework and its different components appear throughout the new guideline. So firstly, this framework and the guideline recognizes and acknowledges the need of all individuals with respect to abortion. It is centered on the values and preferences of the abortion seekers, considering them as active participants in, as well as beneficiaries of the health services. And there are recommendations for each stage of the abortion care pathway, going from pre-abortion, abortion, and post-abortion. And this guideline provides recommendations across the clinical care, health service delivery, and law and policy. And as the individual moves through that abortion care pathway, this guideline provides guidance on the who, what, where, and how. So the how is outlining the service delivery models that can be used. And then the where, information on the locations where services can be provided. Who is individuals who can safely carry out these interventions, and what is the specific recommendation on the interventions needed. Finally, underpinning this framework is the enabling environment, which is the foundation of quality comprehensive abortion care. Next slide, please. So with a person's environment, their environment plays a vital role in shaping their access to care and influencing their health outcomes, which is why we made it a point to focus on enabling environments in that conceptual framework and in this guideline. Next slide, please. So the cornerstones of this enabling environment include: 1, respect for human rights within a supportive framework of law and policy; 2, availability and accessibility of information; and 3, a supportive, universally accessible, affordable, and well-functioning health system. Next slide, please. So restrictive laws and policies regulating abortion risk causing delays in receiving care, or abortion becoming inaccessible in practice. That inaccessibility risks violating a range of human rights of women and girls. In effect, states should take positive steps to secure an enabling regulatory and policy environment to ensure the universal availability, accessibility, acceptability, and quality of abortion care. Next slide, please. Next cornerstone is ensuring that all individuals can access relevant, accurate, and evidence-based health information and counseling if and when desired. And when we speak about the information in this guideline, we talk about 2 types of information that must be available. Information of a general nature for the public, for example, ensuring to provide scientifically accurate, age-appropriate, non-discriminatory education on sexuality and reproduction, including information on abortion. And then the second type is specific information tailored to be relevant to each person seeking that abortion care. So information on where and how to obtain an abortion or contraception, and the specifics of any local laws. Next slide, please. And the third cornerstone we have is the health system. And we refer to the health system to all organizations, people, and actions whose primary intent is to promote, restore, or maintain health. And a well-functioning health system has all these blocks working in harmony. So that's built on having trained and motivated health workers, well-maintained infrastructure, and a reliable source of medicines and technologies, which is backed by adequate financing, strong health plans, and evidence-based policies. And it's also important to note that when we refer to health systems and healthcare services, that this is not restricted to just those provided at a healthcare facility. This guideline is acknowledging the different service delivery approaches, as you will hear more about later. And for next slide, please. For my final slide, these are the health system considerations that are included in the guideline. This includes universal health coverage and primary health care, health financing, health workforce competencies and training, commodities, monitoring, and evaluation. I also want to highlight here that a global competency framework for healthcare workers to provide the full spectrum of care, including quality abortion care, and a set of abortion care indicators are currently under development and will be important products to keep your eye out on in the near future. Thank you.
So moving on to the next section, we have Laura Gill, who would be speaking to us about abortion legislations and the pre-abortion care. Laura is an OBGYN, an abortion provider, and a very active trainer and speaker on safe abortion access. She is a co-founder of an NGO in Colombia. But Laura, I'm not going to take the risk of pronouncing that and messing the name of the organization fully, so I would leave that to you. But beyond that, beyond Latin America, the roles that she's plays a strong role in abortion care advocacy through her positions in FIGO and FLASOG. On to you, Laura.
Thank you, Vinoj. May I share my screen? You need to stop sharing your screen. Great. All right, so thank you so much, Vinoj, for that presentation. The NGO that I co-founded is Grupo Médico por el Derecho a Decidir, which is Global Doctors for Choice, Colombia. So, hello, everybody. So I'm gonna start. Hold on. All right, so setting up all the elements that ensure that abortion will be safe does not only comprise clinical actions. An enabling environment is the foundation for quality comprehensive abortion care. And one element of an enabling environment is an abortion regulation that promotes and protects sexual and reproductive health and rights and achieves positive health outcomes for women. It should promote equity and non-discrimination, and it should avoid restrictions that make others, such as health workers or healthcare facilities or committees, the gatekeepers of abortion by requiring them to determine whether someone fulfills or not the lawful abortion, causing delays and undermining women's moral agency. It should prevent gender-based inequities and knowing that only women need abortions, but also taking care that it avoids inequities among vulnerable subgroups of women like adolescents, poor women, and women with lower education, which are often disproportionately affected by unsafe abortion. So I will not now outline recommendations relating to abortion regulation that comply with all that I said before. So all of the following law and policy recommendations were formulated by expert panels for the development of this guideline, including expert human rights advisors after reviewing the evidence, which included health and non-health outcomes, as Caron just showed us. Abortion care is a medical procedure, and states may not criminalize medical procedures, especially those only needed by women. So the recommendation regarding decriminalization is the full decriminalization of abortion. And this means removing abortion from all penal and criminal laws and not applying other criminal offenses like murder or manslaughter to abortion. And ensuring that there are no criminal penalties for any actor involved in the abortion process, that is the pregnant woman or anyone else assisting the process. So whether it is to provide information or performing the abortion itself or accompanying the person undergoing the process. This will promote that all abortions are safe and all essential health care should be and therefore would help people attain their rights and the highest possible level of sexual and reproductive health. Decriminalization would also ensure that anyone who has experienced pregnancy loss or a miscarriage, a spontaneous abortion, is not suspected of illegal abortion, as it often happens in Central America, for example. The criminalization of abortion does not make women more vulnerable to forced or coerced abortion. Decriminalization is a necessary step for the legalization of abortion, but further legal and regulatory changes may also be required to ensure that abortion is available, accessible, and of high quality. That is implementation of that decriminalization. So regarding grounds-based approaches, which are the most common in the world, the risks to health and well-being of people, they risk the health and well-being of people because they fail to respond to real needs for access and may contribute to unsafe abortion and maternal mortality. And that is why WHO recommends against laws and other regulations that restrict abortion by grounds and recommends that instead abortion should be available at the request of the woman, girl, or other pregnant person. Where they exist, the grounds, they should be revised in favor of making abortion more accessible, and until they are replaced with abortion on request, abortion should be available whenever carrying a pregnancy to term would cause the woman substantial pain, suffering, such as, but not only in cases of rape. Let's not forget also that unwanted pregnancy and forced motherhood pose a risk to mental health, and we should not overlook that. Also, when the life of health of the pregnant woman is at risk, And we should interpret that risk and health definition broadly as per the WHO definition, including mental health, as I just mentioned. It should avoid burdensome requirements, such as judicial orders or police reports in case of rape or sexual assault. And finally, they should realize that then again, grounds-based approaches have a particularly negative impact on the most vulnerable women. So regarding gestational age limits, pregnancy can be safely ended regardless of gestational age. There's techniques for every gestational age, even above 20 weeks. So WHO recommends against laws that prohibit abortion based on gestational age limits. Any age limit lacks any scientific or biological or public health basis. International human rights law requires that regulation of abortion is evidence-based, scientifically and medically appropriate, and up-to-date. What evidence do show is that women with cognitive impairments, adolescents, younger women, women living further from clinics, and women who need to travel for abortion, or less educated women, poor women, and unemployed women are the most affected by gestational age limits, which makes them discriminatory. And that's why we recommend against those gestational age limits. So moving on to more particular recommendations during pre-abortion care, but also as a continuum across abortion care, I want to remark that provision of information and counseling should always be available. And the rectangle here in my slide indicates the recommendations that have been updated since previous guidelines. So who should provide abortion counseling? Hold on, this is on the way here. So for counseling provided by community health workers and traditional and complementary medicine professionals, there is no a strong recommendation rather than a suggestion or weak recommendation as it was before in the previous guideline. And for pharmacy workers and pharmacists, they are now also included in the recommendation as a suggestion or weak recommendation, given that the information is balanced, which means that they include both medical and surgical methods, and that effective referral for surgical options is given in case they are chosen. So for pre-abortion preparation, we will now go through additional recommendations related to issues of law and policy that are more particular for pre-abortion process as they are implemented at the moment of pre-provision. So mandatory waiting periods delay access to abortion and thus undermine the right to health. They may also increase the cost of abortion and compromises confidentiality as they make women need for disclosure to more people because of logistical needs like family care, traveling, and work leaves. They may also result in the continuation of pregnancy and forced motherhood, especially among the most vulnerable again. Fewer resourced women, adolescents, younger women, and those from racial and ethnic minorities, and those who need to travel further from abortion are the most affected by mandatory waiting periods. Regarding third-party authorization requirements, all those women that I just mentioned are the most affected by those third-party authorizations, and abortion should be available on the request of the pregnant person without the authorization of any other individual, body, or institution. Specifically regarding parental or partner involvement in abortion decision-making can be important, but it must be determined based on the individual values and preference of the person having the abortion. And mandated parental or partner involvement is associated with barriers to access an abortion, including delay, forced continuation of pregnancy, anticipated interpersonal violence or exploitation, reproductive coercion, family disharmony, and resource to unsafe abortion. So involving a parent or a partner in the decision-making process must be the pregnant person's choice and not a result of requirements of third-party authorizations. So in the following slides, I am showing you the recommendations regarding clinical services, which have been either updated or add additional to recommendations in the previous guidelines. For a complete overview of all the recommendations related to clinical care, please refer to the guideline. So regarding RH ISO immunization standard, we recommend against anti-D immunoglobulin in administration before 12 weeks, and that goes for both medical and surgical abortion. And standard care still applies for anti-D administration at gestational ages over 12 weeks. Regarding pain management for surgical abortion at any gestational age, we recommend that pain medication should always be offered, such as NSAIDs and NSAIDs, and provided when wanted. We recommend against the routine use of general anesthesia. For pain management, specifically for surgical abortion before 14 weeks, we recommend the use of paracervical block and suggest that the option of combination pain management using conscious sedation plus paracervical block should be offered when it is available. Note that this pain management, is pain management for cervical priming prior to surgical abortion, not the surgical abortion itself. And there are recommendations that speak to the cervical priming itself that we'll be mentioning later in the pre-abortion, in the same pre-abortion section. So we suggest the use of paracervical block whenever cervical priming is being used with osmotic dilators as Dilapan or LAMS. And additional pain management should be considered, such as the use of intravaginal gel, which has been proven somewhat effective. So pain management for surgical abortion at more than 14 weeks is recommended with the use of paracervical block, and we suggest offering combination pain management as conscious sedation and paracervical block. And pain management for medical abortions at more than 12 weeks, that is induction, supervised inductions, we suggest additional methods to control pain or discomfort, not just pain, due to increased pain with increasing gestational age, such as antiemetics and epidural anesthesia or analgesia where it is available. Acetaminophen or paracetamol can be considered for medical abortion at less than 14 weeks if non-steroidal analgesics are not available or could not be used as an option. So prior to surgical abortion, for cervical priming, I told you I was going to talk about cervical priming. So the recommendations has the suggested medication regimen is unchanged, but the misoprostol regimens have been updated in terms of timing and route of administration. And laminaria is no longer recommended as an option before the 14 weeks. The use of osmotic dilators was changed to recommend against dilators. So mifepristone should be used as 200 milligrams orally 24 to 48 hours prior to the procedure, and misoprostol should be used as 400 micrograms sublingually 1 to 2 hours prior. But if it is going to be used vaginally or buccally, it should be used 2 to 3 hours prior. That needs more time to work. So we recommend against, we recommend against the use of osmotic dilators at this gestational age, and the sublingual route is more effective and for misoprostol administration, and we should remember that. So these recommendations therefore replace the prior recommendation. So prior to surgical abortion at all gestational ages, the recommendations replace certain recommendations in previous guidelines, which were for D&E after 14 weeks. So these new recommendations now include information on methods and regimens for cervical priming at different gestational age ranges. For surgical abortions, for more than 12 weeks, we suggest cervical priming prior to the procedure. And for surgical abortions between 12 and 19 weeks, we suggest cervical priming with medication alone. A combination of mifepristone plus misoprostol is preferred, or with an osmotic dilator, that's LAMS or Dilapan, plus medication mifepristone, or a combination of both. For surgical abortion between 12 and 19 weeks, when using an osmotic dilator for cervical priming, we suggest that the period between osmotic dilators placement and the procedure should not exceed beyond 2 days. For surgical abortion at more than 19 weeks, we recommend cervical priming with osmotic dilation and also medication, that's mifepristone and misoprostol, or a combination of both. There was limited evidence for cervical priming for gestational ages between 12 and 14 weeks, and therefore health workers should use clinical judgments to decide the most convenient method for cervical priming prior to a vacuum aspiration for this gestational age range, and misoprostol is commonly used. So regarding cervical primings prior to surgical abortion, who can provide it? So community health workers and pharmacy workers and pharmacists may provide them as long as continuity of care is ensured. I mean, they start care and they ensure that someone is going to continue with the provision of abortion. And doctors of complementary medicine could also provide cervical priming with osmotic dilators, given that they've been suggested to do other transcervical procedures such as inserting IUDs or vacuum aspirations. So we suggest that they may provide it. And lastly, two more general law and policy recommendations that can directly affect safe abortion, the access to safe abortion, even from the pre-abortion phase. So this is my last slide because I know my time is up right now. But provider restrictions, regarding provider restrictions, evidence demonstrates that restrictions on who can provide and manage abortion result in delays, and that burdens in access and abortion. Restrictions also result in administrative burdens and work overload and reduction of the number of available providers. So restrictions limiting which health providers may lawfully provide abortion care that are not consistent with WHO guidance are arbitrary and not evidence-based. By contrast, expanding the range of health providers who can provide abortion care improves timely access to early abortion, reduces costs, traveling, and waiting time, and can make abortion more available in rural areas and at primary health care level, as it should be, preventing unsafe self-management of abortion. And lastly, conscientious objection. Access to and continuity of comprehensive abortion care should be protected against barriers created by conscientious objection, and mostly by abuse of conscientious objection. Conscientious objection continues to operate as a barrier to access to abortion, despite previous WHO recommendations, as it is often misused or abused. It is critical that states ensure compliance with regulations that seek to avoid this barrier, so that conscientious objection is exercised only and only if the provision of quality of abortion can be guaranteed by other professionals. Otherwise, conscientious objection in abortion provision may become indefensible. This recommendation is based on evidence that demonstrates that the negative impact of conscientious objection on access to and availability of abortion care that can even end up on maternal mortality. So lastly, let's not forget that those of us who provide abortions do so based on our own conscience and our clarity that it is a moral obligation to provide this basic and comprehensive care. With this said, and with clarity about all necessary conditions to enable safe abortion, let's move on to provision itself.
That was a powerful close, Laura. Thank you. For the next segment, we will have Dr. Lara Castleman. She is an MD who had done an undergraduate degree in Stanford Medical School at the University of California, followed with the interesting combination of a master's in public health at Johns Hopkins and an MBA from the Wharton University of Pennsylvania. I have been privileged to know Laura personally and professionally over 15 years. Her strong concern for women's rights on health issues has been an inspiration not only for me, but many, many people who know her. Laura, you continue to be an inspiration, and I can't think of somebody else talking in this issue. Please carry on.
Thank you so much, Vinoj. And hello and good day. I am joining you today from Michigan, where I provide abortions, and our laws are very actively changing and undergoing much scrutiny right now. So these issues we are discussing are very near and dear to me right now. Next slide, please. Today, I will be discussing the topic of the abortion provision itself, and over the next few minutes, we'll be focusing on updates related to specifically dilation and evacuation, medical abortion, missed abortion, self-managed abortion, and contraception. Next slide. So specifically to start with updates around abortion provided surgically after 14 weeks, D&E, who may provide that. There have been an expanded recommendation about that, as you can see here, with the new week recommendation that it may be provided by traditional and complementary medical professionals, midwives, and associate clinicians. Next slide. This one is on the what, meaning the regimens for medical management of induced abortion. The top part of the slide, you'll see a carryover from previous guidance of very strong recommendations about combining mifepristone, followed 1 to 2 days later by misoprostol. The route may be according to the woman's preferences. There is also an inclusion carryover from previous guideline of a regimen for misoprostol alone, as you can see here. What is new is the suggested regimen of letrozole, and that is a medication commonly used in breast cancer, repeated for several days, followed by misoprostol for pregnancies through 14 weeks undergoing medical abortion. And this regimen has found to be both safe and, when compared to misoprostol alone, highly effective. Of note, the evidence is lacking in trying to compare it to the combined regimen of mifepristone and misoprostol. Next slide. Here we are talking about updates related to who may provide medical management of abortion. So first of all, to focus your attention on the first row, that is abortion going through 12 weeks. And you'll see an expanded recommendation, including all the categories of people listed here. And the new recommendation is in the box on the left-hand side of your screen. And we are excited to share with you, it now includes a strong recommendation for self-managed care by the pregnant person themselves. And I'll be saying more about that in a few minutes. Of note, the independent provision of medical abortion by non-physician practitioners, the evidence contributing to that was reviewed went up to 10 weeks. The row at the bottom is for medical abortion after 12 weeks. And that, as you can see, has an expanded recommendation as well that's new, a suggestion that the provision can be done by traditional medicine professionals and auxiliary nurse midwives. Next slide, please. So here we are talking about missed abortion for up to 14 weeks. And this is for pregnant people preferring medical management over surgical or expectant management. And in this category, there is an additional recommendation that the combination of mifepristone followed by at least a 24-hour interval and then misoprostol is the recommendation. There is also an alternative regimen shared of misoprostol for the circumstance as well. And for pregnancies over 9 weeks, the misoprostol dosage should be repeated. Next slide, please. Here, we're focusing on a new recommendation regarding who may provide medical management of intrauterine fetal demise between 14 and 28 weeks, who can manage that. And this entirely is a new recommendation. So everything you see here, you'll see on the right, it's a strong recommendation for medical practitioners. And on the left is a suggestion. Of note, the evidence reviewed for this recommendation was indirect. And so the discussions around this did extrapolate from similar guidance related to who may provide medical abortion after 12 weeks. Next slide, please. Now we're going to move into self-management approaches. Next slide. What are the benefits? The list is long, and just to highlight a few of the why part of this, why do we care about self-management? It has many benefits, from being empowering and highly satisfactory to the pregnant person involved, reducing costs and addressing health system shortages. But I would actually really like to focus on the second bullet here. Traditionally in medicine, many of us have really siloed self-management as seen as completely separate from the health system. This new guidance is reframing that, really contextualizing self-management as coexisting within the wider healthcare system, saying that the pregnant person can choose to manage parts or all of it, but if she chooses for parts, that she should be able to then turn to the healthcare system itself for support for other parts of the abortion process. Next slide. So I'm going to walk through this a little bit with you. I know there's a lot on this slide. This is really saying the bottom line of there's now a strong recommendation supporting self-managed abortion in whole or in part for the pregnant person. When I say in part, what are the parts? So it's really looked at in 3 different sections. First of all, self-assessment of am I eligible, meaning how far along is the pregnancy and are there any complications, any contraindications. And so that is now available for self-assessment. Self-administration, meaning managing the process itself, taking the medications. And then lastly, self-assessment of the success. Did it work or not? That the pregnant person herself can manage all that. So the rationale for this really took into account both the existing evidence as on the regimens, as well as the high rate of acceptability for self-managed care. Next slide, please. When we talk about the recommendation for self-managed abortion, it's important for us to remember there are multiple requirements that will contribute to that success. And those requirements are listed here. I want to highlight a few. That includes a requirement for access to accurate information about the process itself, as well as what other options are available to the pregnant person so that she can really make an informed decision for herself about what makes the most a sense for her circumstance. It also requires access to quality medications, both for the abortion process itself, as well as for pain management. It requires access to the healthcare system, to health workers, should the pregnant person need or want to reach to do that for any part of the procedure or any part of the process. And really, I want to also link back to the enabling environment discussed earlier on in the presentation. It also requires that those of us who are clinicians caring for pregnant people seeking abortion care do so in a respectful way, that we avoid punitive approaches to self-managed care, and that we maybe need to change some of our protocols to make that happen. That we also recognize that self-managed abortion is a legitimate pathway to abortion care. Next slide, please. Self-managed care also extends to post-abortion contraception. And on this slide, you'll see focusing on the recommendation around self-administration of injectable contraceptions. This recommendation has been upgraded to a strong recommendation, and that is largely based on the fact that self-managed injectable contraceptions is associated with a high satisfaction and a higher continuation rate when compared to clinic-based injectable contraceptives. Other benefits also include things like financial savings and time savings to the women and girls themselves. I do want to point out that the reason I'm focusing on this in this slide is because it's been an update, but there are other self-managed options that are carried over from previous guidance. Next slide. Those include oral contraceptive pills over the counter, emergency contraception, and condom use. And really, all contraceptive methods should be considered after an abortion. And with that, I want to thank the WHO team for the opportunity to participate in this important work, and turning it back over to you, Vinoj.
Thank you, Laura. The next speaker is Chilanga Asmani, and who's from the WHO regional office in Africa. Unfortunately, he's currently at a location where he does not have internet access. So we would be playing his presentation in a pre-recorded form.
Hello, I will take us through the recommendations on post-abortion care. And we'll start with the recommendations following uncomplicated surgical abortion. abortion or medical abortion, with the recommendation that there is no medical need for routine follow-up visit. This is important to ensure the practice of requesting the client to necessarily come after the abortion services offered is no longer recommended. What is important, however, is the provision of adequate information should be provided to the client so that women or girls or other pregnant persons are adequately informed about symptoms, for example, of ongoing pregnancy, which may or may not indicate failure of the abortion, other medical reasons for return, because the quality of evidence was low to show the need for follow-up or routine follow-up visit after the uncomplicated surgical abortion or medical abortion. Looking at the health worker types who can provide services for the management of uncomplicated incomplete abortion before 14 weeks, we find that for the updated recommendation on medical management with misoprostol allows for the full range of health worker types to provide medical abortion with misoprostol. When we come to vacuum aspiration, the health worker types recommended are from the traditional and complementary medicine professionals going forward. And there's a weak recommendation in favor of auxiliary nurses or auxiliary nurse midwives to offer vacuum aspiration services. And in this case, the services should be provided with assurance that they'll be able to refer, and also the monitoring systems are strong enough in case of need for another health worker type of a higher level, or to be able to provide follow-up care or managing any other complication for this that is beyond the ability of this service provider. Also looking at the management of non-life-threatening post-abortion complications, again for post-abortion infection, the updated recommendations provides a strong recommendation in favor of this intervention to be provided from traditional and complementary medicine professionals up to the specialized medical practitioner. And the same is an updated recommendation allowing for the management of post-abortion hemorrhage from the traditional and complementary medicine professional up to the specialized or specialist medical practitioner. An important service that is should be provided to the woman or to the pregnant person coming for post-abortion care services is obviously the counseling and the provision of the contraceptive of choice. And here we look at the updated recommendation on initiation and continuation of injectable contraception, where the full range of health worker types, there's a strong recommendation in favor of them providing this option of contraception, including the self-care for injectable contraceptives is also strongly recommended as a post-abortion care service recommendation in this new guideline. Over time and with experience on delivery of post-abortion care services, a lot has been shown in terms of different models of service delivery that can be used to provide services to ensure that, depending on the context, depending on the need of the client, access to services could be available. And therefore, there are recommendations coming in terms of what service delivery models are being recommended for the provision of post-abortion care services. For medical abortion services, it is important to note that they can be obtained from and provided or supported by a multitude of actors and also in different settings, as I said, depending on the context, but also very importantly, also depending on the need of the client. And these are looking at how to address this full spectrum of the abortion care pathway, or it could include models for specific component on that pathway. With multiple types of service providers, it is noted that services could be delivered through public, private, or NGO actors. And going forward, we also note that services can also be received at community-based, off-site location, or they can be provided at home, or a combination of these service delivery channels. Telemedicine, by definition, a mode of health service delivery where providers and clients or providers and consultants are separated by distance. An additional recommendation is the option of telemedicine as an alternative to in-person interaction with the health worker to deliver medical abortion care in whole or in part. And this is important to note that with the service delivery pathway, telemedicine could be used to ensure the practice of requesting the client to necessarily come after the abortion services offered is no longer recommended. What is important, however, is the provision of adequate information should be provided to the client so that women or girls or other pregnant persons are adequately informed about symptoms, for example, of ongoing pregnancy, which may or may not indicate failure of the abortion, other medical reasons for return, because the quality of evidence was low to show the need for follow-up or routine follow-up visit after the uncomplicated surgical abortion or medical abortion. Looking at the health worker types who can provide services for the management of uncomplicated incomplete abortion before 14 weeks, we find that for the updated recommendation on medical management with misoprostol allows for the full range of health worker types to provide medical abortion with misoprostol. When we come to vacuum aspiration, the health worker types recommended are from the traditional and complementary medicine professionals going forward. And there's a weak recommendation in favor of auxiliary nurses or auxiliary nurse midwives to offer vacuum aspiration services. And in this case, the services should be provided with assurance that they'll be able to refer, and also the monitoring systems are strong enough in case of need for another health worker type of a higher level, or to be able to provide follow-up care or managing any other complication for this that is beyond the ability of this service provider. Also looking at the management of non-life-threatening post-abortion complications, again for post-abortion infection, the updated recommendations provides a strong recommendation in favor of this intervention to be provided from traditional and complementary medicine professionals up to the specialized medical practitioner. And the same is an updated recommendation allowing for the management of post-abortion hemorrhage from the traditional and complementary medicine professional up to the specialized or specialist medical practitioner. An important service that is should be provided to the woman or to the pregnant person coming for post-abortion care services is obviously the counseling and the provision of the contraceptive of choice. And here we look at the updated recommendation on initiation and continuation of injectable contraception, where the full range of health worker types, there's a strong recommendation in favor of them providing this option of contraception, including the self-care for injectable contraceptives is also strongly recommended as a post-abortion care service recommendation in this new guideline. Over time and with experience on delivery of post-abortion care services, a lot has been shown in terms of different models of service delivery that can be used to provide services to ensure that, depending on the context, depending on the need of the client, access to services could be available. And therefore, there are recommendations coming in terms of what service delivery models are being recommended for the provision of post-abortion care services. For medical abortion services, it is important to note that they can be obtained from and provided or supported by a multitude of actors, and also in different settings, as I said, depending on the context, but also very importantly, also depending on the need of the client. And these are looking at how to address this full spectrum of the abortion care pathway, or it could include models for specific component on that pathway. With multiple types of service providers, it is noted that services could be delivered through public, private, or NGO actors. And going forward, we also note that services can also be received at community-based, off-site location, or they can be provided at home, or a combination of these service delivery channels. Telemedicine, by definition, a mode of health service delivery where providers and clients, or providers and consultants, are separated by distance. An additional recommendation is the option of telemedicine as an alternative to in-person interaction with the health worker to deliver medical abortion care in whole or in part. And this is important to note that with the service delivery pathway, telemedicine could be used in different parts of the pathway. It could be used, for example, at the beginning, it could be used towards the end, it could be used for information of services or follow-up. And therefore, the above recommendation applies to assessment of eligibility for medical abortion, counseling, and or instruction related to the abortion process, providing instruction for and active facilitation of the administration of medicine, follow-up of post-abortion care, all through a telemedicine approach. Approaches such as hotlines, digital apps, or one-way models of communication, for example, reminder text messages that simply provide information, were not included in the review of evidence for this recommendation. There are also some best practice statements on service delivery approaches for the provision of information, counseling, and medical abortion. On the first part, in terms of an additional recommendation, there is no single recommended approach to providing abortion services. And this really reflects to what I said earlier in the earlier part of this presentation, that the choice of a specific health worker or workers from among the recommended options, or the management by the individual themselves, the location of the service provision from among the recommended options, will to a great extent, and important to note, depend on the values and preferences of the woman, the girl, or other pregnant person. Also important to note, it will also depend on the available resources and the national and local context, which differ from country to country. a plurality of service delivery approaches can also coexist with any given context. So in this best practice statement, it's also to note that there could also be a complementarity of delivery approaches. They can coexist, or there could also be a sharing or a combination of different approaches to ensure the availability of the quality services needed by the client. On the second part, given that service delivery approaches can be diverse, it's important to ensure that for the individual seeking care, the range of service delivery options will provide some of these key points: access to scientifically and accurate information at all the stages, ensuring quality assured medicines, including for pain management, which is an important aspect of safe abortion care provision, backup referral services if desired or needed. So when you look at the different delivery approaches, referral support, where else to access a particular portion or a particular part of the service required should also be ensured, and also to link to appropriate choices of contraceptive services for those who want post-abortion contraception. This is also important so that the choice of a contraception option of the client, if it's not available at that particular service delivery center or through the service delivery approach that was selected by the client, there should be an opportunity, there should be a system that this client could be linked to the contraception choice chosen by the client themselves. So in short, this is some of the recommendations in summary that I'm able to present on the aspect of post-abortion care. Thank you very much for your attention.
We are now moving on to the Q&A session. But before that, very quickly, two housekeeping comments. Yeah, we are very sorry that many of you have said that the video of the previous presenter, Chilanga's presentation, was not very clear. What we would be doing at the end of this webinar is sharing the slide deck with all of you for your references. Our apologies. And also, we noticed that some of you have raised your hands to ask questions. I request you to type your questions in the Q&A tab so that we will be able to address that. As you're typing in your questions, we could probably move to some of the questions that we have received, and we have limited time. So Laura Gill, probably I'll start out with a question that's come addressed to you. Simple. Do legal restrictions reduce the number of abortions? Would you like to speak about it, please? Laura?
Yes, I'm here. So evidence shows that no, legal restrictions does not lower the number of abortion because countries with restrictive or permissive laws have almost the same abortion rate. Actually, those with the most liberal laws have lower abortion rates because abortion is regulated as a comprehensive service that comes with contraception and counseling, and that helps in the long term to reduce the abortion rate to those that are absolutely necessary. So no restrictions and laws that criminalize abortions are ineffective because they do not prevent abortion from happening. They just make it unsafe.
Thanks, Laura. And moving on to the other Laura in the panel, maybe there are two questions that probably combine together. So I'm going to put them both to you together and you could look at the way of addressing. One of the first question is, what is the difference between medical abortion and managed abortions? And the second is a question on, is the recommendation that self-management should be the primary service delivery approach? Two questions for you, Laura.
Sure. Thank you, Vinoj. So self-managed abortion and medical abortion, we're being asked about the difference, and I understand it can seem blurry. And That's because it is that medical abortion can be provided a number of different ways. It can be provided in part or in whole through self-managed abortion, or provided in part or in whole through the health system, or again, reframing to say that those are interwoven, that a pregnant person can do part of the process herself and part of the process within the healthcare system. That also often includes approaches such as hotlines and telemedicine. So I wanted to bring that in as well. So no, it's not, self-managed abortion is not being said to be the primary method, but one of multiple options that are encouraged for the woman to have access to.
Thanks, Laura. And please note that some of the questions we are responding parallelly at the Q&A box. Maybe Caron, this is for you. And I'm going to read it as it is. In my setting, not all three cornerstones of an enabling environment are fully in place. The question is, how should we approach provision of quality comprehensive abortion care in such a context?
Great, thank you, Vinoj. Sorry, I was trying to get to my camera and video. So yes, speaking to the enabling environment and those cornerstones. So what's described and what I had presented in the guideline represents an ideal context. So this is recognizing again that the legal, regulatory, policy, and service delivery contexts vary from country to country. So complete implementation of all the components of this enabling environment is not necessarily a precondition to implementation and application of these recommendations that are contained in this guideline. And once again, just emphasizing that the recommendations and best practice statements described in this document aim to allow for and enable evidence-based decision-making with respect to quality abortion care. Thank you.
Thank you. And probably this is for you, Bela. The guidelines has a lot of strong recommendations, but they're asking your recommendation on how is it that WHO would be able to, what is the recommendation on how do we implement these guidelines?
Thanks.
Bela, you're on mute, I think.
No, can you hear me?
We can't.
Can you hear me?
I can hear you very well.
All right, if you can hear me, I will continue. Are you able to hear? All right, I will answer this question in the hope that I am being heard. I'm not entirely sure if that's the case. But Vinoj, you asked what would be WHO's role in implementing these recommendations.
That's right.
And we primarily work in partnership with many of you who are attending this webinar, in partnership also with the governments, ministries of health, and with our regional and country offices. It can seem perhaps a little overwhelming when we see the vast number of recommendations that are contained in the guideline, with over 54 of them, and can leave you with a feeling of, oh my gosh, how do we do this? And it can feel particularly constraining maybe if you feel that the context within your own situation is very far away from what the recommendations are, whether it's health systems, policy, or clinical. But I think the beauty of this guideline is that it allows us to take incremental approaches. We don't have to do everything at this particular moment. We can look at the situation as is within the context of a particular country and look at how we can make incremental progress towards the ideal situation. So the answer is really working to determine what individual situations are and to see how best we can move forward.
So in short, the guidelines is global, but the implementation gets very contextual, I presume. Bela,
Absolutely.
Don't get off the mic because probably we're coming very close to the end of the workshop. So would you like to share some closing remarks?
Well, I think this question itself could serve as the closing remark, that the need to now focus in on implementation of this guideline, and remembering what we've seen throughout this presentation, the need to take a holistic and integrated approach, but to recognize that we may only be able to make short baby steps in the interim, but that we need to have an overall vision of holistic, comprehensive abortion care with a person-centered perspective. So I think that's sort of enough to round off what we spoke about today. But I want to remind everyone that you can look at the guidelines more in depth with a digital version of the guidelines that you can find on the web. You can also, of course, download the guideline in PDF format or its executive summary. So we encourage you to explore all of these resources and get yourself more familiar with the recommendations that we presented here today. And of course, the guideline and its recommendations are not a standalone product, but are within the context of a whole range of products that exist and will be coming in the future months. So you could explore the topic page on abortion. Please look at the Global Abortion Policies database, which will in fact help to contextualize the country context and take the first steps to analyzing where in the spectrum of care you are and what the steps to implementation could be, and to look at the various articles we have around the data that we presented and the fact sheets that we have. So Carolyn, do you want to tell us how we can also continue to stay in touch?
Yes, absolutely. Thank you, Bella. So yes, as you can see, there's really a wealth of WHO products around the topic of comprehensive abortion care. And after this webinar, we will be sharing the slides from this webinar. So that will also include links to all these resources that Bella just mentioned, as well as other resources so that you can easily access them. And yes, it is soon time to wrap up, but there are several ways in which you can still sort of keep the conversation going and stay in touch with us. If you enjoyed this webinar, you can view it again and you can share it with others. Again, we will be circulating the slides and information about how to access the recording from today. And also, if you would like to get in touch with the WHO Prevention of Unsafe Abortion team, you are welcome to send an email to this email address that you can see here on the screen, and that we will also share when we share the slides. Also, if you enjoyed this webinar, I would really encourage you to join the IVP Network platform. This is a digital space where you can interact and network with thousands of other people around the globe who are interested in SRHR issues. You can get updates on other upcoming webinars and events that IBP is hosting, and you can receive news about other WHO guidelines and tools that are being released. To sign up is free of charge. It only takes a few minutes, and you simply go to ibpnetwork.org to sign up. As a member of the IBP platform that I just mentioned, you also will have access to several different communities of practice on different SRHR topics, including a community of practice that's specifically dedicated to comprehensive abortion care. So I really do encourage all of you who have joined us today to also join this community, which will give you the possibility to share your own knowledge with others, post questions, and get updates about recent research and other events related to abortion care. So on that note, I would like to close this webinar. And once again, we all thank you for taking the time to join us today. And I hope to see you soon again in one of our upcoming webinars. Thank you very much, everyone, and enjoy the rest of your day. Bye.